We're gonna go ahead and get started. So there's a lot to get through.
Yeah, Chris.
So my name is Chris. Anybody that hasn't met me, I'm one of the ICU pharmacists. I mainly work in the CVICU in the days, and I kind of float around the different ICUs at night. So we're going to talk about hemodynamics today. So first, we're going to go through the pathophys, and then we'll get into the real meat of the lecture. So the ultimate goal of your hemodynamic system is to deliver oxygen to the tissues and facilitate aerobic metabolism. So you have oxygen consumption, which is your VO2, and your oxygen delivery, which is your DO2. So when everything's working properly, you have a balance to maintain adequate perfusion. However, if you have an inadequate DO2 or your oxygen delivery or your oxygen demand goes up, then you can have anaerobic metabolism, and this leads to potential ischemia. So this is going to be pretty interactive. I'm going to ask you questions. I want you to actually give me answers. If not, I'll just call out my MICU crew that I know have seen this before, maybe. So first question, what affects oxygen delivery to the tissue? So I heard perfusion, so like, yeah, your blood pressure, and then hemoglobin, yeah. So your perfusion, hemoglobin, and your oxygen saturation, the hemoglobin and oxygen saturation make up your oxygen carrying capacity. So hemoglobin is affected by not only how much hemoglobin you have, but it has to also be functional. So in patients with methemoglobinemia or carbon monoxide poisoning, it will reduce the functionality of the hemoglobin that you do have. And this is why you'll see packed red blood cells being given if your hemoglobin is less than 7 and you have shock. Your oxygen saturation is also affected by the amount of oxygen that's in the air, as well as your lungs' ability to pull oxygen from your blood supply. And so for that, you'll see patients that are requiring O2 if they're on the vent or on high flow. And so who can tell me the equation for blood pressure for the perfusion side? Not saying you're wrong, but does anybody have? Yes, it is. So now someone tell me what SVR means. Yes, thank you for reading the slide. So it's the amount of vasoconstriction in your blood vessels. It also can be called your afterload. And then what about cardiac output? We'll get to that. Yes, very good. But yeah, it's the blood ejected from your heart per minute. Very good. So we have afterload, which is comprised of both your SVR, or systemic vascular resistance, and your PVR, which is your pulmonary vascular resistance. And so the SVR is for the left side of the heart. The PVR is for the right side of the heart. So these two both comprise your afterload, and that's what your heart pumps against to circulate blood. And then as far as cardiac output, like I said, it's measured in liters per minute, and it's affected by your volume as well as how many beats per minute your heart is going at. And so when you have an afterload reduction on this side of your blood pressure, that's why you can see a compensatory increase in your heart rate to try to maintain your cardiac output. So I think someone already said it, but cardiac output is your heart rate times your stroke volume. And so who can tell me what the components of your stroke volume are? So preload and contractility both make up the stroke volume. That's correct. And so does anybody know, like in layman's terms, what your stroke volume is? That's right. Yep. Perfect. It's the amount of blood that your heart is pumping from your left ventricle per beat. If you're noticing that I'm repeating your answers, it's because we're also recording, so just bear with me with that. So if you go back to the previous equation, cardiac output is heart rate times stroke volume. You can also calculate your stroke volume if you divide cardiac output by your heart rate. And then cardiac contractility is measured by both your right and left ventricle ejection fraction. And what makes up your preload is the amount of fluid that you have to eject by your heart per minute. And so you can measure this two ways. One way is with a central venous pressure or a CVP, and that measures the fluid on the right side of your heart. And the other way is the pulmonary capillary wedge pressure, or PCWP, which measures your fluid status on the left side of your heart. So the pulmonary wedge pressure is more invasive. So what you'll typically see in the ICU is utilizing a CVP, because the pulmonary wedge pressure requires a swan. And so I did want to, for just completeness sake, mention that you still have to remember the RAS system. So that's the renin, angiotensin aldosterone system. And this also plays a role in both the venous and arterial tones, but it's not really utilized much in shock. It's more outside of the ICU managing chronic hypertension. So now let's get into more questions about which receptors affect your afterload. So which receptor affects your SVR? So that's going to be your alpha-1 receptor. The thing about that is causing, when you agonize or stimulate your alpha-1 receptor, you'll squeeze down on your pipes or your blood vessels. And then what about the pulmonary vascular resistance? I'm hearing some whispers of beta-2. That's correct. So think about albuterol. So albuterol is a beta agonist, opens up the lungs and allows you to breathe better. So what receptors affect our heart rate and our contractility over on this side? Yeah, that's right, beta-1. So all of these are utilized and contribute to your blood pressure, and they all relate to shock. And so now we'll move more into the meat of this presentation, which is kind of determining types of shock, and then we'll move into the different pressors and inotropes, that kind of thing. So how we treat your shock is going to depend on what type of shock that you have. And so what we can do is look at these boxes. So you have CVP, cardiac output, and SVR. Remember, your CVP is your preload, your SVR is your afterload, and how heart rate and stroke volume contribute to cardiac output. And so based on what's going on in the patient and the type of, will help you determine what type of shock that they have. So what kinds of shock are considered distributive shock? Yes, septic shock's the big one. You can also have vasoplegic shock, which can happen in patients after cardiothoracic surgery from being on bypass. And then anaphylactic shock also falls into this category. So what is your primary problem if you have sepsis? If you are very sick and you have an infection? Not saying you're wrong, but does anyone have any other thoughts on what your primary issue is? Well, 50-50, you were close. It's low. So your SVR is your primary issue. You have a loss of vascular tone. So if you think about it's your systemic vascular resistance really low, so you have very dilated blood vessels. And then sepsis is caused by inflammatory markers and cytokines that are over-released in the body. And so you'll have a patient that'll have a normal capillary refill because they can't vasoconstrict their blood vessels to preserve any perfusion to their vital organs. And so that's why you get the organ dysfunction in sepsis. And as opposed to an anaphylaxis type of shock, this is also distributive, but it's caused by an IgE mediated release, and it also causes a reduction in systemic vascular resistance. So next question, how are CVP and cardiac output affected in distributive or septic shock? So let's start first with CVP. So you have your patient that's hypotensive likely. What's the first thing that you would give them? Okay, so how do you think their CVP is before you give them the fluids? Right, it's going to be low. So then as far as the cardiac output, it's a little bit more dependent on the timing. So typically you get the capillary leak and you have fluid that is leaking out of your intravascular volume. And so that's what leads to third spacing. And so even though you aren't actually losing fluid, your CVP will be low. This is why the fluid resuscitation initially is really important. It's also why there's a new thing coming around a lot more nowadays called deresuscitation. And so you'll see patients having to get diuretics and things like that to kind of deresuscitate them after their fluid shifting goes back to normal once their distributive shock has resolved. And as far as cardiac output, initially you have a hyperdynamic phase of sepsis. So you'll see your heart rate being high and your contractility increasing, but eventually that catches up to you and your body can't keep compensating for it, and you'll have a drop in your cardiac output because your heart just gets too tired. So moving into hypovolemic shock, what are the main causes of this? Bleeding is a big one. Another one that can happen, although it's less often, is just water loss. So if you have someone with persistent vomiting, diarrhea, or if they're just not eating or drinking anything, you can see it. The most common is going to be blood loss. Another common patient population that we don't see here very often is burns. So burns have a lot of extra fluid loss just from their skin not being intact anymore. So what's our primary issue in hypovolemic? That's right. So your preload is lowered because you don't have any blood in your vascular system or water. So how would you expect your cardiac output and your SVR to be affected? So this time, let's start with your SVR. Right, so you don't have enough fluid in there, so you're going to constrict down and try to do what you can with what you have. So that's what your body's trying to do no matter what's going on. It's trying its best to maintain hemostasis. And so you would see kind of a similar issue as with distributive shock with your cardiac output. So you can initially see it be unchanged or increased, and then eventually, again, you will see a decrease after a while. And then the final two I kind of combined. So cardiogenic and obstructive, because they can present in similar ways. So what kind of things can cause cardiogenic shock? Heart failure is a big one, and there's one more. A STEMI. And then what are the main causes of obstructive shock? Clots. So PE in your pulmonary artery, cardiac tamponade, which is basically a buildup of fluid around your heart sac. This just inhibits the ability for the heart to be able to pump effectively. So what's our primary problem in cardiogenic and obstructive shock? Yeah, by process of elimination, cardiac output is going to be the one that's affected the most here. And so I mentioned with a STEMI or with, a STEMIs and heart failure exacerbations, your heart's just not able to get an adequate pump. And then in obstructive shock, again, you don't get the adequate pump because it's not able to push against the clot, or it's not able to push against the fluid that's building up around the heart. So how would you expect your CVP and your SVR to be affected? So this time we'll start with the CVP. It'll be increased. Yeah, just think about your typical heart failure patient when they come into the ICU. They're usually pretty fluid overloaded. And then as far as your SVR, yes, it's also increased. So your SVR increases in an attempt to try to maintain your blood pressure. So if you think back to the blood pressure equals cardiac output times SVR, so your cardiac output's going down, and so your SVR responds by going up. Unfortunately, you can get in kind of a cause and effect relationship where you don't have any blood moving forward, and so your CVP goes up, and this causes pulmonary edema. And this is pretty typical for heart failure patients. The pulmonary edema makes it harder for your heart to pump, and so as a result, your SVR goes up even further, and it just continually loops and gets worse and worse, and you start circling the drain. Okay, so now we're going to move into kind of an overview of the different vasopressors and what receptors they hit. So you can see with norepinephrine and epinephrine, they're the two most common ones that I see. And so you have pretty adequate alpha effect with both. However, with epinephrine, you have more beta activity. And so thinking back to where the alpha 1 works, it works by increasing your systemic vascular resistance, or it increases your squeeze in the blood vessels. And so you can see increase in blood pressure that way. Because of the beta 1 effects and epinephrine causing the increase in contractility and heart rate, you really don't see it as much as norepinephrine, unless you need to increase your heart rate or have some inotropic effects that you're desiring. So this is really more of a third line agent as far as the MICU. We use it a little bit more after cardiac surgery because you do need some inotropic effect after you've done an open heart surgery on people. So you'll see it more often there. Then looking at dopamine, dopamine is my least favorite vasopressor because it's not really clear on what receptors you're going to hit all the time, depending on what dose you're at. And it's just not very desirable. So you can see that it hits mainly the dopamine receptors at the really low dose. When you get to the moderate doses, it adds mainly beta 1 receptor activity and then a little bit of alpha. And it's not until you get to the higher doses that you see what you'd be looking for typically in a septic patient, which is increasing your alpha 1 activity. But you don't drop off the other receptors, you just add on. And so you still have the beta receptor activity as well as the dopamine activity. And so there was a trial that was done called the SOAP2 trial that looked at dopamine and norepinephrine and found that dopamine was a lot more rhythmogenic, and this is why. So this is why dopamine isn't really used that much. It would probably be my last ditch effort behind even phenylephrine for someone with shock. I will say, I always plug this, but the one time I've actually seen it used and used appropriately is if you're ever at a code and you're on the floor and I'm not there and you don't have any other pharmacists in sight that can make you a drip and you don't have anything to make a drip, then you can use dopamine because it's always in the crash cart. And you can use it as a bridge to when you get them somewhere that you can actually have an epi drip. So that's probably the one time I would suggest pulling it out. And then phenylephrine is the last one. So it has mainly alpha activity and no beta activity. And so you can see that used if you have a patient that has a high heart rate or if they're an AFib, that can cause kind of a reactive bradycardia. And so that can be beneficial in patients that are in AFib. So that can be an intervention that you can ask the doctors about if you see that happening in your patients. It's something that I'll bring up. One thing that's a little bit more counterintuitive to me is using a beta blocker combined with norepi. And I think that it should kind of stick in your minds too, just to ask, like, why do we want to do both? Because you're basically counteracting each other with the beta 1 activity. So you're blocking beta and also stimulating beta at the same time. And so the better answer could be to use phenylephrine instead of norepinephrine. So the one I haven't mentioned yet was vasopressin, and that's because it doesn't really fit on my schematic in the first part, so I have to kind of stick it here instead. So vasopressin works differently than all the other vasopressors. It works mainly on the vasopressin 1 and vasopressin 2. Vasopressin 2 is in your kidneys. Vasopressin 1 is found in your smooth muscle in your veins. And so you can use vasopressin to increase your blood pressure by causing fluid retention in the kidneys, and it also increases your SVR. And it's really nice because it doesn't really have effects on your heart rate or contractility, so it's a really good add-on for norepinephrine. Now, who can tell me the dose of vasopressin that we use? Do we titrate it? No, we don't titrate it. We just do it at 0.4, 0.04, and it's either on or off. The reason that we use only 0.04 and we don't titrate it is because if you go above that, you can see some gut ischemia, and we don't like that. So this is just a refresher on all the sites of action. And as a reminder, just the ultimate goal is providing efficient oxygen delivery through agonizing these different receptors, basically pulling on which lever you need to do to either bring up this person's blood pressure through cardiac output or their systemic vasoresistance. So more things that you guys care about with like central lines. So these are preferred with central lines. A peripheral midline is okay for if you're going to do it for a short period or while the doctors are working on getting a central line placed. But the issue comes up for extravasation, which is not fun and very ugly looking. So we don't really have a protocol for when you have to have a central line, when you don't. But I would say generally, if you're going to be using a high dose of a vasopressor, and if you're going to be using it for over 6 hours, I would ask the provider to order a central line or put one in for you. If you do get extravasation and a peripheral line, make sure to tell the provider first things first so that they are aware of it. And then you'll use, you can use phentolamine or hyaluronic acid to prevent necrosis, especially if it's caught early. And just as a reminder, when you're using a peripheral line, just to use the largest gauge that you have, if possible. So that's a picture of the phentolamine, just in case you wanted to know what it looked like. Okay, and then as a reminder, norepinephrine, epinephrine, and dopamine all affect the beta receptors and can cause tachycardia. And this is kind of going back over the dopamine and norepinephrine trial that saw no difference in the ability to achieve MAP goals, but you did see increases in ventricular arrhythmias. You actually saw increased mortality in patients with dopamine and cardiogenic shock. So don't use dopamine. Now, let's go over how you would treat septic shock. So I know we've already mentioned the fluids. So what else do you want to do for someone that has septic shock? What do you do before the antibiotics are given? Yay! You get the cultures first. Okay, so we got our cultures, we gave our fluids, we're still hypotensive. What's next? Yes, which is our preferred first line pressure? Norepinephrine, very good. What is our ideal second line vasopressor? Vasopressin, yes. And then if all that doesn't work, you can add steroids. Hydrocortisone 50Q6 is the right dose. You can also see 100 milligrams Q8, but I like 50 Q6, so that's what I like to go with. So the mineralocorticoid activity increases the release of catecholamines from the adrenal gland. And it's believed that septic patients might have a relative adrenal insufficiency. That's why they're requiring the pressors. So this can help with them. In most patients, you'll just see the hydrocortisone, but certain providers, depending on who's rounding that week, might also add fludrocortisone in addition to the hydrocortisone. This is typically most commonly seen with Dr. Haywood. I'm not aware of which other providers do and don't, but I've seen it kind of both ways. As far as the fluids of choice, you want to make sure it's a crystalloid fluid. LR is preferred over NS at this point because you can see incidences of hyperchloremia when you use NS, and so LR is more balanced. And not all patients respond to steroids, so if they're really not getting any benefit from it, it's okay to just DC it. So we'll move on to the hypovolemic shock. And so the number one thing for hypovolemic shock is, yes, definitely give them back blood if they need it, fluids if they need it. But ultimately, what's going to help the most is source control. So if they need to go to the OR, they need to go to the OR and it needs to get fixed. If they need an EGD to fix their GI bleed, then that's where they need to go. But again, this would also be crystalloid fluids with LR preferred over NS. And so it's important to know that if your patient needs blood, then that's causing the loss of the hemoglobin to carry the oxygen, which is causing imbalance in our oxygen delivery. So even if their MAP is being adequately controlled with fluids and just fluids, then you still might need to give blood products if they're if they don't have enough hemoglobin. The other thing that's not on here that I'll make a brief mention about, I won't get on my true soapbox about it, but albumin is restricted until you have at least given 30 mils per kilo of crystalloids. Albumin doesn't really improve your clinical outcomes better than crystalloids. And so it's actually better to do the crystalloids first. And then if that's not working, then to do the albumin. And so just keep that in mind. Okay, so this is probably less my expertise and more what you guys can look at a lot more. So ways to determine if your patient is fluid responsive. My favorite one is the CVP because I actually know how to do that one. You can just look at the number that you guys get me. So if it's less than 8, you might benefit from more fluids with your patient. The other one is the passive leg raise. Taylor, do you know how to explain this better than I do? Because I'm not very good at it. Yes, absolutely. Please, my guest appearance, Taylor.
Okay, passive leg raise. So some of you guys may have seen this. Pretty much for us to get reimbursed by CMS, we have to do a dynamic fluid assessment, fluid responsiveness challenge. And one of them is the passive leg raise. For this to work, your patient needs to have an arterial line, or the provider needs to be standing over them with an ultrasound. We have this imaginary 250 cc to 300 cc bolus we're working with. You're going to set them up really straight for that 60 to 90 seconds. Let this imaginary bolus drain to the legs, and then you flip them back on their back. Maybe have a friend come help you hold their legs up for that 60 to 90 seconds. We're letting this imaginary bolus come to the heart, and they should assess for this 10% increase in pulse pressure on your art line. So basically we're going to see, can the heart accept this fluid? It likes it and it's going to push it forward. And if we have that 10% increase, it's saying yes, this patient would probably benefit from some fluids. If not, it's more likely maybe we should titrate up on a Levophed or whatever pressors you have going. Maybe fluids are not the answer at this moment. So it's something you can do dynamically a few times and just see which one. If they're fluid responsive or not. Yeah.
Thank you, Taylor. You would not have lied to me explaining that. So.
You could have done it.
And then other things that providers can do is looking at pulse pressure variation on the ventilator and IVC collapsibility. These things I'm not well versed in, so I won't try to explain them and butcher it. But if you ever see a provider doing it, you should definitely ask them to show you how they're doing it. Okay, so moving on to cardiogenic shock. How do we fix someone with cardiogenic shock? Yeah, that's not a bad idea. Inotropes can be beneficial in patients with cardiogenic shock. I'd say first things first, I would try to treat what's causing it. So if you have someone that's coming in with a STEMI, then the ideal thing is to send them to the cath lab and let's get some fibrinolytics or reperfusion therapy going so that we can open that back up. Other things you want to do, evaluate fluid status. This can be a lot more nuanced than just your typical, just give them 30 mils per kilo. This is going to be more of evaluation of, okay, well, how much fluid do they need? Are they fluid overloaded if they have heart failure? Before I would consider an inotrope, I think the first thing I would do is look at arterial vasodilation with agents like nitroglycerin or nitropresside. So looking at that to reduce the demand on the heart by reducing your afterload. But the issue is with that, some patients have really soft blood pressure, and so that may not be the best idea. Another way to reduce your pulmonary arterial pressure, if you have a patient with really bad pulmonary hypertension, is using inhaled EPO. And so that won't have an effect on your systemic blood pressure. It will just have an effect on dilating the blood vessels that are getting oxygenated well in your pulmonary vasculature and allow you to have better gas exchange at those vessels. And it doesn't really work at the sites that aren't getting good blood flow and so or good airflow from your areoles. And it won't work in those sites. And then, like you said, inotropes are a good option. And also, if you have a patient who's in bad enough cardiogenic shock, you could end up needing mechanical support with ECMO or balloon pump or Impella. Most of those patients are going to go to the CV ICU, which is where I live in the morning. So you'll get to see my happy face rounding with the physicians if you're in there, and you might get to deal with some of these things. So looking at the inotropes, the two main ones are dobutamine and milrinone. They are slightly different. So dobutamine is primarily going to work on your beta 1 and beta 2 receptors. It also has a slight alpha 1 agonist property. So if you think about beta 1, you're increasing your inotrope and contractility. And then beta 2, you would think, okay, well, that's going to lower my blood pressure because it causes vasodilation in my pulmonary veins. But the alpha 1 activity actually counteracts it and provides a small amount of systemic vascular resistance increase. So you usually don't see as much of an effect on your blood pressure. Now you do see arrhythmias with both of these, but with milrinone, the difference is you do see more hypotension because it works in a different way. So it works on your phosphodiesterase 3. It increases nitric oxide production, and this is what can decrease your pulmonary vascular resistance. But it also increases calcium influx into your heart, and it increases contractility that way. One thing to consider with milrinone, it's renally cleared, and so you'll see the duration of action get longer with renal dysfunction, and so you can see more of the hypotension and arrhythmias because you'll see that it's building up in the body. But it is advantageous for use in someone with pulmonary hypertension because it does relax your pulmonary vasculature. So I would say in the MICU, I see more dobutamine. If you're in the CVICU with me, you'll see a lot more milrinone. So we're going to move into some cases to kind of bring it all back home. So we have a 57-year-old female presents with a productive cough, fever, altered mental status. Blood pressure is pretty low. It went up a little bit after 1 liter of fluid, and her CAT fill is less than 3 seconds, so it's pretty good. So what type of shock do you think this might be? Septic shock, that's right. So like I mentioned before, you get normal capillary refill that indicates that you have a good or a normal amount or decreased SVR. Even though you have hypotension, you still see that you have good cap refill. If you had vasoconstriction in the peripheries, you wouldn't see as good a cap fill. And so that's kind of one clue. Other clues are that the patient's fluid responsive. And so what type of treatment would be good for this patient? So we gave him a little bit of fluid, 1 liter. More fluid, yeah. Fluid's always good. 30 mils per kilo is ideally what you want to get to. I don't know a lot of people that 1 liter would be 30 mils per kilo. That's a pretty small person. I'm certainly not that small. And then after the volume resuscitation, we already talked about this, but what's your next move? Oh yes, definitely antibiotics. Get those cultures where the antibiotics go in. And then still hypotensive after the fluid. Pressors. When do we add the steroids? After vaso, yep. So if you have 2 presses on board and you're still hypotensive, that's when you want to consider adding the stress dose steroids. All right, case 2. 65-year-old male with no past medical history, found unresponsive, low blood pressure. We haven't given any fluid yet, and our ultrasound shows poor ventricular motility. So our ventricle is not doing good, and your capillary refill is greater than 3 seconds. So what type of shock is this likely to be? Yeah, so I would argue it could be cardiogenic, could be obstructive as well. So the first thing I would do would be to check a CVP and see how that looks. And you would do that from a central line and then decide whether or not you need to give diuretics. You kind of have to be careful in patients like this with fluids because they could have a low ejection fraction and a reduced ability to pump blood through their heart. And so you don't want to make that worse. And so as far as the differential diagnosis being cardiogenic or obstructive, the main things you want to check for, that you can check for on an EKG, you can look for a STEMI, or you can do imaging to look for a PE with a CTA. And so what kind of treatment do we think would be a good option for this patient? Let's say we ruled out PE, they don't have a clot, it's cardiogenic shock. They're pretty fluid, they're kind of fluid overloaded. We don't want to do anything there. Yeah, vasodilation. So we want to reduce the afterload. So that'd be great. And then possibly inotropes once we've reduced our afterload as well. Nice. Okay, that's our last case. Case number 3, 32-year-old female with septic shock with MRSA who's on multiple pressors on norepi, vaso, and epi. Blood pressure is 95/76. So get your calculators out. Hint, hint. Patient's also on steroids. So based on the heart rate and blood pressure and all the other things, what change in their medication therapy would you like to do? Yeah, drop the epi. So if you calculate the map, it's actually like over 65. I don't know the exact number off the top of my head, but it's a good map. So in that case, trying to wean off some of the vasopressors is a good idea. It's just a reminder that you don't always have to add something just because someone is getting better or getting worse. You can utilize what you've already got going. Okay, and before I finish, I wanted to do this plug because I've been seeing and hearing more a little bit about insulin orders and them being held. And so I wanted to kind of go through this. Lauren and I and some of the other ICU pharmacists are working on trying to get a better, more in-depth diagram, but this is kind of what we have so far. So take that with a grain of salt. Don't judge us too hard. But I'm kind of going through this flow sheet. So you have active orders for insulin. First step is your patient NPO. So that's like true NPO. Depends on if they're on tube feeds or not on tube feeds. So if you have a Levemir that's ordered, starting all the way on the right, the Levemir is long acting. The onset takes a couple hours. So you'll see, like if you have a patient with DKA and you start Levemir and you're planning to stop the insulin drip, that's why there's an overlap. just kind of for clarification there. But it doesn't really have a peak. And so you have this long, slow burn of insulin. And so you really shouldn't have to hold it, regardless of if a patient's NPO or has a diet or tube feeds, whatever the case may be. So it shouldn't be held even if their glucose is normal, unless you have an order from a provider to hold it. And then moving to our left, or yeah, our left, my right. If you have an order for insulin aspart, it depends on whether it's ordered as just a sliding scale insulin or as a scheduled mealtime insulin. And so there's kind of a difference there. So like a scheduled would be 6 units with meals, like no sliding adjustment. And then sliding scale obviously has the range that you would base it off their glucose. So in the case that it would be a patient that's NPO that has scheduled insulin aspart, which is the short acting, it has a really short onset and actually has a pretty good peak at about an hour. And so if a patient is NPO, you would want to hold it, but you'd also want to contact the provider to let them know, like, hey, we probably need to hold this. Can you put a hold order on? Or can we just DC it in the interim? But if a patient's NPO and has scheduled aspart that's not sliding scale, then I would want to hold that. If they are NPO and it's just sliding scale and their blood sugar is like 180, above 180, then I would go ahead and give them the sliding scale and not the scheduled meal time. So it's really ideal for when they're actually eating a meal. And the same is sort of true with the insulin regular. I see insulin regular as a better use for patients that are on tube feeds or TPN, because you're getting a constant influx of calories rather than just short bursts. So if you look at the difference between regular insulin and insulin aspart, the peak takes about an hour or two longer to occur. And so you can see more dose stacking or hypoglycemia after the patient's eaten if they're on insulin regular. So I see it more used in patients that are on tube feeds, but the same would still apply. If it's sliding scale, even regardless of whether their tube feeds are running or not, I would still treat based on the algorithm and the protocol. If they're on a scheduled insulin regular and their tube feeds are held, like 6 units every 6 hours, and no adjustment for what their blood sugar is, then I would consider whether or not to hold it, and ask the provider if you should be holding it or if you should be giving it. Because that's, again, any of these that they're scheduled and they're not eating with these shorter acting, it can cause some hypoglycemia. But with the Levemir and longer acting, it shouldn't cause hypoglycemia, even if they're NPO. Okay, and then I'm going to open up to any questions about the entire hemodynamics and then the little blurb I just did on insulin. What questions you guys got? I'm sure I didn't do that totally perfectly. On a pump. A pressure bag? No. Oh, I like pumps, but I know that there's a shortage of pumps, so you don't always have a pump available. Well, so from a med safety standpoint, giving a bolus without a pump isn't like the most safe thing, which is what we're trying to address with our new IV pumps that we're trying to get, like that's kind of in the works in the future. But running anything to gravity is like a med safety issue. So ideally everything should be on a pump, but we realized like that's not possible. So you can set a pump bolus to go, I think as high as like 999. And so it would go in over an hour. Does that answer your question, or just raises more questions? Yeah, okay. Okay, yeah, I mean, that makes sense. I think it's probably more provider specific than on And just to repeat the question for the recording, Taylor asked if a provider orders a 1 liter bolus, should it be in a pressure bag or on the IV pump? Any other questions? I think if you're actively resuscitating a patient, then you might have a provider that's kind of near or at the bedside. But usually when I see a bolus that is ordered, specifically ordered, it usually the max it gets ordered as is a liter over an hour. But if you're just at the bedside and the physician is asking you to give them a fluid bolus and doesn't necessarily put in an order, and they want it given over a faster period of time, and you need to do a pressure bag, then I'm sure that will be kind of relayed with the order. Does that make sense? So the question is there ever a blood sugar level that I should hold the levomir, or should it always be given no matter what? And so if their blood sugar is less than 70, that's when I consider it to be hypoglycemia, and I wouldn't want to give it in that case. And even if their blood sugar is less than 100, I start getting a little bit more concerned. And so it might be a valuable question to ask the resident or the provider that's taking care of the patient, like, hey, their blood sugar is this. Do you still want me to give the levomir? But I wouldn't just inherently hold it. Even if it's low, I would say, like, let's hold off on giving it, but let's tell the provider so that we can get like an intervention to like maybe decrease the dose, hold the dose, something like that, instead of just purely holding it, if that makes sense. Absolutely. It's one of my, like, I wouldn't say call it a pet peeve, but I've been trying to get on my soapbox more about it lately. I'm sure you'll see this more in the CVICU after cardiothoracic surgery. So a lot of times in that unit, when you have a patient that's fresh off an open heart surgery, they'll be on an epi drip that's not titrated by the nurses. It's titrated by provider order only. And so you might end up with a high blood pressure and you have to start carding, which is very counterintuitive because you're increasing their blood pressure and decreasing it, and you just need the inotropic support at that point. And so my ideal situation would be to switch that patient to dobutamine, in which case you won't get the blood pressure effects like epinephrine provides. And if you're still needing carding after that, and sometimes milrinone can be a really good option because it'll actually lower your blood pressure. I'm sorry, the question was if you have a patient on epi and nicardipine, if there's a better option for inotropic support. I'm not really used to doing recordings, as you can tell. These are good questions. What other questions y'all have? Okay, if nobody has any other questions, I really appreciate y'all listening to me ramble on for 45 minutes. And I hope y'all have a good rest of the day.